Welcome to part 2 of Addiction in Primary Care, where we will expand on the services available in our clinics. In this lecture, we will focus on 4 different services that we provide, which is OSCAR, methadone replacement therapy, quit smoking clinic, and alcohol intervention program. First service, OSCAR Clinic or One-Stop Center for Addiction. The objective of a one-stop center for addiction is a holistic and comprehensive facility dedicated to providing all-encompassing support and services for individuals grappling with addiction. At such a center, individuals can find a range of resources and assistance designed to address the complex and multifaceted nature of addiction. To sum it up, OSCAR is a community-based service that provides screening, intervention, and treatment for substance use or abuse. In OSCAR Clinic, we also manage dual diagnosis and comorbidities. We provide services for drug use psychosis, anxiety, and depression related to drug use. In our local setting, we also provide psychosocial, spiritual intervention and counseling. These are some of the services provided under OSCAR Clinic. The mode of operations are as listed below and discussed in part 1 of our module. Patients can be recruited from multiple points of entry into OSCAR, specifically for patients who has any history of substance use. It could be from walk-in or voluntary patients, patients from methadone clinic or quit smoking clinic, even our existing NCD patients with any risk factors, or referrals from outside. OSCAR requires a multidisciplinary approach and teamwork from doctor, paramedics like medical assistant and nurse, counselors, and social worker. Each member of the team plays an important role in the management and maintenance of patients with addiction. This is the flowchart management of substance abuse in OSCAR, where a walk-in case registers, then proceeds to be triaged before further assessment and appropriate treatment is given, and a follow-up appointment is required. One of the main treatment for opioid dependency is methadone replacement therapy, or MDRT. So let's get into it. Methadone therapy began in 2005 as a drug substitution program to curb the spread of HIV caused by needle sharing among drug abusers. Throughout the years, the program has had many names, from drug substitution to drug replacement and maintenance therapy, particularly in opioid use disorders. Now, these are the 3 main objectives of methadone treatment therapy, based on the latest 2016 policy and guidelines. Based on the same guideline, the methadone therapy policies are clear, where each patient must be registered and properly documented. There is no limit to number of patients enrolled. This methadone therapy is free for all Malaysian citizens, and it can only be prescribed by registered medical officers that have undergone verified formal methadone therapy training by MOH or by attachment in a methadone treatment facility for 5 days. Other policies are that the prescription needs to be renewed at every review and can only be dispensed in liquid form by a registered medical officer, pharmacist, or assistant pharmacist, also with formal training. Dispensing methadone also has to be done daily through direct observation therapy or DOTS. Take-home doses can only be given to stable patients according to the clinical judgment of the treating medical officer. A patient should fit the inclusion criteria stated on this form if being considered to enroll in a methadone therapy program, but any queries can be brought forward and discussed with the family physician in the treating clinic or specialist in the referred clinic. So how does methadone work? Methadone is a synthetic opioid agonist similar to morphine and functions to suppress opioid withdrawal and cravings for about 24 hours, making it the ideal replacement drug and treatment drug for opioid withdrawals. It is also important to advise patients, from understanding its pharmacokinetics, that methadone effect needs at least 2 weeks to stabilize. This is because it varies from patient to patient. Even with the same dose, the concentration in the blood is not the same for all patients. Peak concentrations can be achieved between 2 to 3 hours. Thus, it is important to monitor patient for toxicity at least 4 hours. By each hour, the effect of methadone may increase until it reaches a steady state. Side effects can include sleep disturbances, some sexual dysfunction, and constipation. Now, new patients should be dosed with caution. Deaths in the first 2 weeks have been associated with doses in the range of 25 to 100 mg per day, most occurring at doses of 40 to 60 mg per day due to heroin intake concurrently during this phase. This is why the starting dose at induction should be between 20 to 30 mg per day. Patients need to be observed for 3 to 4 hours after initial dose for any symptoms of withdrawal or intoxication. Ensure to patients that symptoms can be tolerable and will resolve by 1 week as it reaches an adequate dose. It is most important to have rapport with patient and be honest about withdrawal symptoms. Stabilization of dosage is aimed in the first 2 weeks, thus the need for patients to be seen daily in clinic, although patients may or may not reach an optimal maintenance dose. Further dose adjustments may be required after patients have been initially stabilized. Treatment monitoring should be done regularly, and patients should be observed prior to dosing. A medical officer must review the patients at least once in the first week for proper assessment and make a consideration for dose increase. It's important to note to not increase the dose for at least the first 3 days of treatment, and increments should be done by 5 to 10 mg every 3 days. When patient is already regulated and stabilized, a follow-up review will look at a few things. Maintenance dosing, where generally higher doses are required for maintenance. Preliminary data from a Malaysian sample indicates an average dose between 35 to 50 mg per day. Compliance can be monitored through daily administration, as non-compliance is associated with an increased risk of relapse. A urine analysis should also be done at every review to objectively measure drug use. Now, methadone overdose can lead to death and may occur at home during sleep. So how to avoid methadone overdose? Number 1 is to give early morning dose to ensure that peak methadone concentration occurs when patients are awake and other people are around. When and if it occurs. If patient has had a history of overdose or you feel is at risk, prolong the observation time to longer than 4 hours. Also, preemptively warning the family members on signs of overdose. And lastly is having naloxone on hand. Now, methadone overdose is life-threatening, and recognizing signs and symptoms as listed here is important, and to continue with basic life support with the administration of naloxone. Naloxone is a pure opioid antagonist and has excellent absorption, and it comes in different preparations, from intranasal, intramuscular, intravenous, and nebulized naloxone. However, in our setting, we only practice giving intravenous naloxone. It is the single most important drug in methadone or opioid overdose. Referral for admission should be expected as well. In the case of methadone overdose, if there is respiratory depression, 2 mg of IV naloxone should be administered. A repeat dose of naloxone should be given every 2 to 3 minutes. If no response is elicited, however, if a total dose of 10 to 20 mg of IV naloxone was given without any response, other causes of coma should be investigated. An observation of up to 10 hours should be done for cases of suspected methadone overdose before allowing discharge. If patient is asymptomatic throughout the observation, if naloxone was given in a suspected overdose, however, patients should be admitted and monitored for at least 24 hours. Now, these are some medications that can cause a drug interaction with methadone. It may decrease serum methadone concentration, it may increase the concentration, or increase adverse effects of methadone. Thus, history of past and present medication and comorbidity is important when enrolling a patient into the methadone program. Missed doses are common in patients, even for addiction patients on methadone. So if doses are missed for 3 or more days, tolerance is reduced, causing patients to be at increased risk of overdose. So to restart the medication, we must follow the reintroduction guide below. Now, voluntary methadone withdrawal is when patients on methadone replacement therapy decides to discontinue or taper off their methadone use. Now, this decision is made willingly and is part of the overall treatment plan. However, it should be approached cautiously following these listed steps, as abrupt cessation of methadone can lead to severe withdrawal symptoms and may increase the risk of relapse. Involuntary withdrawal can also occur for various reasons, like violence against staff, repeated non-compliance, or failure to follow rules. In managing voluntary withdrawals, dose reductions should be made in consultations with patients where they are comfortable with the reduction regime, and signs and symptoms of withdrawals were explained as it may begin to rise as the daily doses fall below 20 mg per day, and symptoms may peak by day 3 after cessation of methadone. Now, some of the withdrawal symptoms, like disturbed sleep, can be managed with good sleep hygiene and simple relaxation techniques. Other issues, like excessive sweating and reduced libido, may benefit from reducing the lowering of methadone dosage, like instead of 10 mg reduction weekly to 5 mg reduction weekly. Now, let's look at a case scenario. This is the usual presentation of clients to methadone or Oscar Clinic in KK setting. Now, as explained before in Module 1, history taking, which includes a very thorough drug history, need to be done with the aim to establish that the main drug of addiction is an opiate, and to address drug use, whether the client fulfills the criteria for substance use disorder, or to establish that there is evidence of dependent use. Now, criteria for dependent use have already been explained before in Module 1. So let's say this is what you get from the further history. So we decide to start him on methadone today. So what were the questions and assessment that need to be done before deciding to start methadone? Now, prior to starting methadone, a doctor needs to ask any history of methadone use before, any complication, any side effects, when is the last heroin intake, to make sure that it is at least more than 6 hours, to look at any evidence that patient is in withdrawal state, also needs to be assessed by using the clinical opiate withdrawal symptoms or via subjective complaint by patient. We also need to explain to patient regarding methadone therapy, the side effects, titration dose, and symptoms to suggest any toxicity. We have to explain that methadone therapy is drug substitution therapy for opioid use disorder and will be given as long-term maintenance therapy. Patients need to take the treatment as daily observed therapy and enroll in psychosocial intervention to ensure success of therapy. Now let's move on to the third service, which is the Smoking Cessation Clinic. It is a service available in all Klinik Kesihatan across Malaysia. Now, the first step in treating tobacco use disorder is to identify tobacco users among patients who present to our healthcare facilities. For those with tobacco use disorder, brief clinical intervention by physician increases the quit rate. 5 major steps, or 5 A's, are brief and time-saving. For step 1, the first thing we should do is ask. We should screen tobacco use status for every patient at every visit, including adolescents. All you have to do is ask. Now, for step 2, tobacco users should be advised to quit smoking in a clear, strong, and personalized manner. For example, to be clear, you can say, I think it is important for you to quit smoking now, and I can help you. Cutting down while you are still ill is not enough. An example of being strong, you can say, as your clinician, I need you to know that quitting smoking is the most important thing you can do to protect your health, now and in the future. The clinic staff and I will help you. In step 3, we assess the willingness to make attempt to quit by using the Stages of Change model. Now, this model provides a useful framework to help healthcare providers identify smokers and assist smokers in quitting. We've already mentioned this in part 1 of the module as well. For example, for those in pre-contemplation stage, we provide motivational interviewing using 5R. However, unplanned attempts to quit are as likely or even more likely to be as successful as planned attempts. Thus, there is benefit in encouraging all smokers to consider quitting whenever the opportunity arises. As mentioned in the previous slide, these are the 5R of motivational interviewing to enhance patient motivation to quit smoking. Other than assessment on willingness to quit smoking, it is important to assess the level of addiction, as this can help to predict likelihood of withdrawal syndrome and guide the usage of pharmacological treatment. So the level of nicotine dependence can be assessed using modified Fagerstrom test, which is available in both English and Bahasa. Now, step 4 is assist in quit attempt by using the acronym of STAR. S for set a quit date. Ideally, a quit date should be within 2 weeks. Reduce the number of cigarettes before the set date. T. Tell family, friends, and co-workers about quitting and request understanding and support. Patients should also encourage other household members to quit with them if they smoke, or not to smoke in their presence to minimize risk of treatment failure and also exposure to secondhand smoking. A is to anticipate withdrawal symptoms like irritability, restlessness, increased appetite, and even insomnia. At this point, we can discuss challenges or triggers and how patient will successfully overcome them. We provide them with problem solving or skills training. We can also recommend the use of pharmacotherapy at this point. And finally, R, to remove tobacco products from his or her environment prior to quitting, as it can provide a supportive healthcare environment while encouraging the patient in his or her quit attempt. So total abstinence is essential, not even a single puff after the quit date is set. Another method that we use to refrain patients from smoking is by administering 12M advice. Now for the final step is to arrange a follow-up. The evidence suggests that multiple treatment sessions increase smoking abstinence rate and its effectiveness, and continuous abstinence is achieved when patient has not smoked for at least 6 months. Let's get into the pharmacotherapy. So agents for pharmacotherapy are divided into nicotine-based and non-nicotine-based. The choice of first-line pharmacotherapy should be guided by 4 main factors, which is efficacy, safety, suitability, and cost. Now, NRT or nicotine replacement therapy helps to reduce withdrawal symptoms associated with stopping smoking by replacing the nicotine from cigarettes. Now, there are 4 different NRT products available in Malaysia, including the patch, the gum, lozenges, and inhalator. But in our settings, we only have nicotine patch and nicotine gum. The availability of different dosages from 10 to 25 milligrams patch or 2 milligram and 4 milligram gum might vary depending on the district or the clinic. Now, the evidence suggests that no overall difference in effectiveness between different forms of NRT. Adverse effects from using NRT are related to the type of products, like skin irritation from patches and irritation to the inside of the mouth from gum and lozenges. There is no evidence that NRT increases the risk of heart disease. If the person is not ready to stop smoking straight away, NRT can also be used to help reduce their smoking before they stop. Currently, varenicline, however, is not available in our setting as previous products were recalled due to contamination of potential carcinogen. For smokers with time to first cigarette or TTFC of 30 minutes or less, may benefit from putting the patch immediately before sleeping, so that the plasma nicotine level is highest upon waking up 6 to 8 hours post-application of the patch. Now here on this page, you can see the prescribing instructions, precautions, and side effects of nicotine gum as well as nicotine patch. Now these are some of the infographics and instructions to guide patient on using nicotine patch and nicotine gum. This is very important during consultation. For varenicline or non-nicotine-based medication, common side effects used to be nausea, abnormal dreams, and sleep disturbance. More serious adverse events like cardiovascular events, depression, and suicidal ideation as well as suicide have been reported, although these are very uncommon. Last but not least, we'll go into the alcohol intervention program for alcohol addiction. Now, alcohol is a legal and easily accessible substance in most countries, including Malaysia. Based on NHMS 2019, like we discussed in part 1, we know that men has a significantly higher prevalence of alcohol consumption at 15.8% as compared to female at 6.2%. Now, WHO recommendation of low-risk drinking is not more than 20 grams, which is equivalent to 2 units of standard drink per day, 5 days per week. However, excessive drinking is defined as more than 21 units per week in male and more than 14 units per week for female. Alcohol consumption generally can be classified as alcohol use, alcohol abuse, or alcohol dependence. In the past, alcohol consumption was classified into use, abuse, and dependence. But with the update in DSM-5, alcohol use disorder is now stratified according to severity, where 6 or more symptoms is classified as severe, 4 to 5 symptoms considered moderate, and 3 symptoms or less is considered mild. Now, there are three different modalities to measure the alcohol level in the human body, from blood, urine, and breath. Although 90% of alcohol is metabolized in blood, the rate of alcohol elimination depends on age, gender, ethnicity, and also comorbidities, with an average of 0.015% per hour. These are the listed signs and symptoms of alcohol intoxication and alcohol withdrawal. It is important to know the percentage of alcohol that is contained in the beverages that are available in our country. So low alcohol with percentage of less than 10% are considered from beer, ale, and stout, while medium alcohol levels, 10 to 20%, are in wine, tua, and toddy. And the ones with high percentage of alcohol are brandy, spirit, whiskey, and any liquors. This is the recommended approach for alcohol addiction in primary care. So first of all, after full clinical and physical examination, we need to assess the stage of change for the patient. Second, assessment of risk category using the screening tools. We must also calculate the standard drink of alcohol consumption. Only after that, we can deliver brief intervention and most importantly, harm reduction for the patient. As mentioned in part 1 in the previous slides, stages of change in addiction is important. This is to determine the proper management for our patient as mentioned before. In reality, a patient can jump between stages, go backward and forward, even be in more than one stage at a time. Now, for risk assessment in alcohol addiction, there are several tools available. The most commonly used screening tool in primary care are, number 1, CAGE, the self-administered interview, which has 4 questions, and Audit 10, which is Alcohol Use Disorder Identification Test, which is also a self-administered interview with 10 questions. It is validated by WHO and available in many languages. Now, the Alcohol Use Disorder Identification Test, Consumption, or Audit C, includes only 3 questions from the full audit. Based on Audit 10, total score helps to categorize patients into low risk, hazardous, or harmful dependency, or high risk and addiction. Now, this is a flow chart from our local guideline for community regarding alcohol consumption. Patient can be screened using Audit 10. Based on score and category, can help to determine our next step of management for patient. For example, if patient goes under zone 1, where he is low risk, we need to educate patient regarding alcohol consumption and recommend a limit of alcohol consumption to prevent any harm or to prevent addiction. However, if patient comes under zone 4, where there is high risk and addiction, after brief intervention, we need to continue monitoring and also refer the patient if needed. There is 4 main steps to help us in calculation of standard drinks. Step 1, we need to know the type of alcohol patients took. Step 2, we have to get the percentage of alcohol in the drink. Step 3, we have to estimate the quantity of the drink in liters. And lastly, we must calculate the standard drink based on the formula, which is alcohol quantity times percentage of alcohol times 0.789, which is a constant. So how many standard drink can we calculate? Let's use the example below. For example, a case of patient that takes 1 can of beer. 1 can equals to about 0.32 liters. It contains 5% of alcohol. So 0.32 times 5 times 0.789 equals to 1.3. And we have to round out the answer to equal 1 standard drink. Now, how about local drinks that are made in our own country, like toddy, tua, or montoku? So here are the listed rough estimation of quantity. So a brief intervention approach for addiction can be used for alcohol is also the mnemonics of FLAGS, which is feedback, listen, advise, goals, and strategies. Now this graphic explains each part of the mnemonic in more detail, such as giving individualized feedback about risks with continued drinking, listening to patients' response and any false beliefs or worries that they may have, to discuss safe drinking limits or assisting patients in setting specific goals to change their pattern of consumption. Studies show that patients that was given an early and brief intervention in all forms of addiction benefited either through reduction of alcohol use, changing patients from pre-contemplation stage of change to contemplation stage, and even from initially not agreeing for referral to accept referrals. Congratulations! We have now come to the end. And when it comes to addressing addiction in primary care, there are several key take-home messages to keep in mind. Thank you for joining me in a short learning module of addiction in primary care. I hope it has been beneficial, and you can find the references and guidelines with acknowledgements at the end of this slide. Thank you.